Good afternoon. So I stand between you and your lunch. So I'll try to make it interesting so that you can postpone it for a while. For about 1.5 decades, I have worked in health informatics area as a research and as for building technology. Recently, I've also started looking at visualization and analytics. So basically, we are already, if you have data, then what do you do kind of scenario. I will just introduce electronic health record in one single slide and hope that it will be enough. And then I'll talk about what do we mean by long-term preservation, what are the challenges, what are the strategies, how do you manage preserved record, what will be the utility once it is preserved, and finally I'll present a conclusion. Now, as per standards and standardizing body, electronic health record is a repository of information regarding the health of a subject of care in computer processable form. So it has to be about health, it is a record, and it exists in computer processable form. Also, in terms of what it covers, the other definition is that it is a longitudinal electronic record of patient health information generated by one or more encounters. So we are already talking about a period under coverage. Now there is a lot of debate about terminology of EMR, EHR and all of that, but recently we have started using a term in our community called womb to tomb, which basically means that the record about a particular person starts at the time of conception, which can be distinguished from the mother herself, because the medical sciences have advanced to a level where doctors can perform fetal surgery. So where do you put this record? Do you put this record along with the mother, or do you put this record as a separate entity? Then what do you call that entity? Hospitals have used a nomenclature called child of and mother's name for a long, long time, because in India, the child name is given after a particular ceremony, so that may happen sometimes 3 months after birth. So till that time, the child is known with some pet name, or the hospital record, even some of the birth record for that matter, carry the name child of and mother's name. And later on, the family or the mother has to file a court affidavit and put a name in the new, and a renewed record is provided. So you're talking about these kind of scenarios. So what do we mean by long-term preservation? And the first question is, why preserve EHR? Now, I know that we are already talking about preservation of electronic record, but let me tell you, every electronic record and health record are a little bit different. Different in the sense that you want to preserve it for a particular purpose, not only because it is your heritage or culture or something like that. You want to preserve it for certain utility. And the problem is that those utility are going to compromise on two very basic things that you want or expect from your health record: privacy and confidentiality. So as soon as you start preserving it for utility of scientific exploration, drug discovery, let go of these to a certain level. So the first question that everybody starts asking, if we have lived for 1,000,000 years as human being, about 10,000 years as civilization, never preserved health record, what's the necessity now? But it is not so. It's not that we have not kept medical record as such. There are medical records of certain people from the very, very ancient time. In our own country, Charak Sahinta and Sushrut's treaty are known to carry huge amount of medical detail, in which these sages have described medical procedures performed on patient and described that patient's medical record, leading to which a surgery or a medication was prescribed by them. And I'm talking about period something like 1500, 2000 BC. Much of it progressed obviously by word of mouth, etc. In fact, I was reading an article which says that some of the hieroglyphics on large pillars in Egypt, which was dedicated to known people as a kind of a trophy or a memento, it carries records of medical history. My father and so had this disease, passed away so-and-so, date, etc. And therefore I raise these obliques in the name of. So we have been preserving it, maybe for a different purpose. Now there was a very seminal study, very recently conducted, called DOHAD study. Every medical technologist talks about it, where an approach was taken to finally see whether there is a scientific linkage between historical record of health and your present and most probably future health state. And that study says that it is very important. The historical context is important in order to understand the association of disease and the early medical and related history. Now, what is pointed out as need is that there are various studies which are being undertaken now with billions of dollars being pumped under Obamacare and EHR meaningful use in the United States, and several such programs in Northern Europe, Canada, Australia. Will it reduce the cost of medical care? The recent studies that have come, which says some of them categorically denied, they say no, it actually increases the cost. Obviously, because you are building the cost of capturing the medical record, preserving it, and using it into the cost of utilization, which for a beginning of a certain amount of period will be higher than the returns you will get from it. But once you have this repository for a long, it's like saying that what is the importance of building a library because it's going to be very, very costly. It is going to cost you in the beginning, but once you start storing artifacts into it, it turns into a treasure trove of information. And that is what you should aim for. So in the beginning, it is going to cost. However, there are evidences that it leads to reduction in cost of medical care itself, which is one of the goals of preserving the EHR in the first place. Its biggest contribution, we feel, and from the analytics perspective, is in the study of the epidemiology. We are still studying the records of bubonic plague. We are still studying the effects of, or what led to and what were the medical effects of Great Bengal famine. So I'm talking already about 300, 400 years of gap, and then also mining and trying to correlate information contained in some very sparsely contained and preserved medical record from those times have led to enormous understanding, because our own understanding as science and technology is increasing. We are able to now see two unrelated items which were present at that time, not recognized, and today we can interrelate them. We can understand that these two brought together do make up information worth collecting. Also, it will bring some speed up into the medical processes. There is an amount of unwarranted cost. Almost every hospital, every clinician suffers with a mentality called, I have not done this test, and therefore do it again. So if you go to a clinician, he'll say, blood test karna hoga. Say, I've just got it done 10 days back. No, that's too old. Let's get it done. For some of the record, you do want immediate, but for many record, you may not. I have been to a very few doctors who say, if you have spondylitis, so maybe a 2-month-old or 3-month-old X-ray would suffice. I can look at that and then I can check you physically and come to some conclusion about it. There are certain programs going on as we speak of around the world. And we did, as part of study these projects of national EHR. And as you can see, classic third world countries and in fact second world countries are absolutely missing from this list. Now, in India, the joke between technologists is that India leapfrogs technologies. We decide that something is required, we go and study whatever is available, and then we leapfrog. So that's what is the idea of doing again. So we studied all these 11 programs as it is there, and we made some meaning out of what went right, what went wrong. In fact, the literature is absolutely divided, starting from NIH program to Meaningful program to Medcom program. Some study squarely say that it is one of the most fantastic thing to happen, and some of them absolutely say there is the worst thing to do. It has increased the cost, it has made things impossible, there is huge queues before GPs, and so on. So the idea is to learn. In India, we have started working on it. In fact, recently, just about 3 months back, the Ministry of Health and Family Welfare, which is the apex policy-making body in India, the Union Ministry, came out with a notification which says these are the standards to be used for creating EHR in the very first place. Not necessarily preserving it, but if you are a clinician or a hospital or a health service provider, you need to have certain kind of EHR, PHR, EMR, whatever you want to call it now, and those have to meet certain standards. I had the privilege to serve on that committee, and this is based on several ideas already existing. In fact, this committee never gave any India-specific standard at all. we simply picked whatever was most dominant or appeared to dominate or will dominate in near future in a particular segment of healthcare. So there are standards for creation, there are standards for transmission, there are standards for storage, there are standards for security, and so on. So there is a huge set of standards. It runs into several pages. Also, my team in C-DAC, we started working on a technology project which was funded by DAT, which is also funding this conference, where the idea was, is there a possibility of developing a basic framework technology on which several services can be later built, but the idea of the basic framework is, can you bring around technological pieces to make it possible to capture health record of more than 1 billion people of India and make it available from anywhere and in a consolidated form. So the idea was not to approach it from social engineering perspective or to try to change the economy or try to change the society as such, but look at it from a technological perspective. It was more of a research prototyping. Now, in terms of preservation, you want to cover medical data, but the problem is that medical data itself is now spread across geographies. Yesterday night I was in Pune, today I am in Delhi, and today evening I will be back in Pune. Same for most of you. Now, that does not mean that we don't travel and we don't fall ill while we are traveling. We do. And many times we go to the local GP, whoever is suggested by a friend or a colleague, and we go and our medical record gets created there. Today, the population is upwardly mobile. That's the fact of life. And then how do you collect it when your record itself is spread across geography, and I may not have a copy? Let me tell you that. I have 35 years on this planet, and I still don't have copy of everything that had happened to me or for which everything I was treated. Also, there is this ubiquity of medical devices and computer devices. So as new iPhone comes or something else comes, and then you struggle to bring some health app onto it, they generate new kind of data, and then there's this rushing thing. But we know that aggregating EHR from all sources is worth preserving, and therefore we should do it. The entry barriers are, of course, why EHR in the first place? The doctors ask, why do we need it, etc. And we are trying with several studies already saying that there are known benefits. And then there is this reluctance. Are we ready for it? Why should we do it? I'll do it once somebody else does it. First you make government hospitals do, then I will do it, and all of that. So what are the challenges in preservation? First of all is that a huge amount of medical data, at least in this country, exists in non-electronic form. That is the biggest challenge. So what do we do about them? Then how do you preserve it? Because you have a problem of locations, you have a problem of standards, you have a problem of format. Then for what duration and size you should kind of cater to when you're talking about preservation, because life expectancy is increasing. Recently, WHO report says that in India, the life expectancy, male and female, has got to 64, 67. That means from conception to life expectancy in general, 67 years for a female. And then you add the need to have it in your system so that research can be done on it. You're talking about a century worth of data remaining in active access before you can basically archive it out and say, we will bring it when you need it. The access, security, and privacy is one of the key and teething barrier. In fact, refuse of somebody, a escape button. Say, I'll not do PHR because this is what is the problem, access, security, and privacy. Hardware and software obsolescence, and obviously the technological aspect of how do you interconnect all this system. What about fail safety? What is going to be the performance when you're talking about billion people and everybody having a certain amount of sizes? So we are already talking tera and zettabytes. And how do the systems scale? Do we have to build one national system, one great day, and everybody starts using it? Or can we do it in bits and pieces? And then how do they scale together? So there are various strategies. It's all in my paper, and some short on time. I'm just going to cut short through it. But there are strategies. Some of them are very radical. Some of them are need-based. So you start from the very beginning. You start from a particular date, or you do a conversion of a need-based thing. But the problems are still there. For example, the standards themselves change. We see standard as once you standardize, your game is half won. But it's not so. The standard themselves will change. HL7 started with 1.0, now is 3, it's working on FHIR and so on. So will happen to DICOM standard, one of the very dominant is in 3.0 version. What happens to the backward compatibility? Not all systems are backward compatible, not all systems are supposed to be backward compatible. I'm sure much of us did our original thesis and college work in WordStar. Those files are not even supported by current generation Office programs. So it's all lost. Of course, another bigger problem from technological perspective is the enormity. How do you do it? Various programs that I mentioned earlier, they've used different approach. One of them is that data remains local and a registry is built at a central location. Everybody first queries the registry, and if a permission is granted and you have specific authorization, etc., then you can pull it from the local end. But that also is another problem. The solution immediate is that you centralize all data, but then it's too huge to be kept at one single place. One solution being proposed is that you do a scalable distributed system, or you do hierarchical or multi-level storage, and so on. For security, there is, just 5 minutes more, there is no silver bullet for security, and various mechanisms are there, you can look through it. For hardware and software obsolescence also, there are various data center and warehouse guidelines, we can look at them. So it's not that these problems are not there, or these problems are very specific to health only. These problems are there everywhere. Wherever you will talk about preservation, you will talk about hardware and software obsolescence, the same will apply here. Now, the bigger problem is the management of preservation. Once you have it, once you start collecting all of it, how do you manage it? Because control and governance is an important factor. And without clear knowledge about who owns it, who collects it, who delivers it, etc., is going to be all meaningless. Now, this is what I call a retention rule tangle. 3 different agencies in Government of India have given 3 different retention period. Medical Council of India gives an ethics guideline, says every clinician should preserve record for 3 years. Now, the problem is that many hospitals think that it does not apply to them because they are not clinicians, they are health service providers. So, Director General of Health Services, which is a apex body for decision making, says that 5 years for outpatient, 10 years for inpatient. That's the record you should preserve. And these are only for paper based. So, we have not even begin electronic preservation. Okay. Once you say that it's electronic and you can carry it in pen drive, the feeling will be perpetuity. States in our country, because it's a union of states, have prescribed different period. Like Punjab says 12 years of all medical record. Now, I'm very, very sure that it's not being followed. There can be several approaches towards this problem also. What do you do? How long you retain? But my first thing is, please homogenize the time requirement, or at least categorize them and then say that this kind of record needs to, for example, everybody is getting cough and cold, maybe we don't want to keep it, we'll just keep an aggregated number. He fell ill 20 times, that's good enough. But for certain surgery, etc., you would like to keep the record. Certain very important and long-term disease like cancer, you would want to preserve it for a very, very long time, and so on. Ownership of record is also an unresolved question. When I search through it, there are legal issues across the world. There is no clarity on who owns the record, because the medical record is subjected to contracts, tort, copyright, evidence, and then IT Act. One section of these laws enough to send you to bar, behind the bar, and we are talking about application of whole host of laws here. So there's huge problem. Now, thankfully, in the EHR standards recommendation, the committee recommended that let's adopt it that the patient is the owner and HSPs are only custodian. But it still does not solve the other legal issue which hasn't been challenged yet. Is the state powerful enough to be custodian of record, or is it only the health service provider? So if government starts saying that no, you need to keep your health record with me, are they infringing on your right? It's over, sir. Yeah. So there is this governance model. There are already governance model. One of the bigger problem is that it's in state subject. So every state is free to make their own rules about health in India. But there are programs and models that can be followed there as well. Utility, I have just put 2 perspectives. One of them is individuals, where obviously you can access it from anywhere. It reduces your cost. The treatment can be tailored made for you, and it can give you a better insurance handling. From the society and HSP perspective, availability of medical record itself makes it a big asset to mine later. Patterns and correlation, drug efficacy, management information, etc. In the end, I'll leave you with the slide that I propose that it is complex, I agree, but it is a required activity. We should do it. The benefits far outweigh the challenges and they are not unsurmountable. We have to fix on a policy and move on. EHR needs to be preserved during the lifetime and maybe later also. India has moved on various fronts and we are trying to leapfrog. And with advances on ICT and healthcare, preservation will become an imperative. So it's already upon our doors. We better just move ahead. Thank you very much.
Thank you, Mr. Gaur.